to grow it. And we've seen plenty of growth. So we're pleased to tell you what a little bit about what we do today and about our clinic and how we can help patients.
Hello, everyone. Okay, so we're going to do an overview of the Aspire's Tick-Borne Illness Center. We're going to go over tick identification, acute Lyme disease, and other tick-borne illnesses. We're going to go over the Infectious Disease Society of America guidelines versus the ILADS guidelines, and then chronic borreliosis and complex tick-borne illnesses.
We did have some cases that we prepared at the end, some 4 brief cases to tell you about that we'll let you guess on the answer to because we find it's a good way to kind of to bring it home at the end.
So as Dr. Thatcher mentioned, the Aspire's Tick-Borne Illness Center opened in 2019 in Woodruff. It was started by the Howard Young Foundation and also Open Medicine Institute. And we later joined with Ascension and then Aspirus. The main goal of the center was to provide a place of hope and healing for patients who are suffering from chronic tick-borne illnesses. And we did expand services to tick bites and acute infections as well. Providers include Dr. Thatcher and myself.
And we're hoping if things get busy enough this summer, maybe we'll even start being able to take on an extra person. We'll see. It's the clinic has been fully funded by the Howard Young Foundation since its inception. So any red months, we are supported by the Howard Young Foundation, and we're very grateful for their support.
And we are a unique center in that we are part of a major health system, which is kind of unheard of for a tick-borne illness center. But so far, it's been a pretty positive experience, and we get referrals from a lot of providers and a lot of different health systems as well.
If this is, if this little experiment of having a tick-borne illness center that's a cash shop, working with a large medical system works out, there is hope that in the future we could replicate this business in other places. Especially knowing that Aspirus now has a foothold in northeastern Minnesota, that would be a potential target.
So the current services that we offer at the center, we do tick bite prophylaxis. We do treatment of acute tick-borne infections and treatment of complex chronic tick-borne illnesses. In the future, we hope to offer some other services, and I'll let Dr. Thatcher touch on those.
Yeah, we've had, like I said, we've been blessed by donors, and we had some donors step up over the past year to donate funds to help us to implement at some point in 2026 an infrared sauna, some different red light therapy mats to help with pain, also a soft shell hyperbaric oxygen chamber, and there's other things that we're looking into too, and we hope to be able to expand into IV infusions in the future. We do talk about this mentorship program. The spirit of the Howard Young Foundation grant is to collaborate with other physicians, whether it's in Aspirus or outside of Aspirus. Also to attempt research to help to further the knowledge on acute and chronic Lyme disease. And we also our door is always open for providers to shadow us at the very least, for especially providers that are in the primary care setting, be it urgent care or primary care or even ER. So if you know any providers that are interested in learning more, all they have to do is email the ticks. Well, you can email my address on there too, but also ticks@aspirus.org is our generic email that goes to all of us. So if anyone's interested, they can send a CV to my email address or to the TICS email at the same aspirus.org and let us know when their availability is. And Ashley, I would welcome them with open arms, be it an NP, an RN, a PA, or a physician as well. And similar, when I did my rotations, I would have them work with both of us if they came.
Okay, and then we also offer specialized testing. So one of the tests that we use most often is IGeneX. IGeneX is a lab that is located out in California. They're kind of the gold standard for tick-borne illness testing in the Lyme world. They have more reliable tests and more accurate tests for Borrelia, Bartonella, and Babesia. So they offer an immunoblot, which is going to give you more strains. They also offer enriched culture, a fish test, and PCR testing. And again, the benefit to the IGeneX testing, the big benefit is that you're going to get multiple strains compared to what you can get through the CDC testing.
Most of us have heard of the Western blot, and the immunoblot, I like to call it the Y2K version of the Western blot. A lot of hospitals have retired the Western blot and implemented an immunoblot, and it's very easy to do. So if you have hospitals near you that are still checking with Western blots, it's a pretty easy phone call to acquire the immunoblot. The fish testing is neat because so many times we do an IGeneX test and the antibody testing is negative, but then the fish is positive. So fish testing being direct testing, literally catching it in the act. So that's quite useful. And the PCR, we tend to use that more for biopsies. So if someone's getting, or for fluid. So if someone's getting a knee tapped, and there's fluid available, it can be sent for PCR. That way, instead of, in addition to looking for Borrelia burgdorferi, one of the agents for Lyme disease, you can check for multiple Borrelia. And inside that IGeneX kit, there are other collections for specimens. I've had kids send their tonsils when they're dealing with pandas, and skin biopsies. So many of our patients get skin biopsies, and it's inconclusive. And knowing that Bartonella being one of the main things that tends to cause skin lesions, being able to have the ability to send a PCR of that tissue is quite useful.
So these are a few slides on tick identification. So this is the black-legged or deer tick. You can see it has a sesame seed shape. It's got the burnt orange body. It's very small, and it is polymicrobial, so it can carry Borrelia, multiple forms of Borrelia, Babesia, anaplasmosis, and Powassan virus. The nymphs, so the very small one, if you can look at the picture of the ticks on the fingertip. The second one from the left is the nymph, and that one is the most high-risk tick because it can feed on you without you knowing because of its size. And so usually those are the ticks that transmit infections the easiest.
And we say three things about ticks when because they really don't want you to know that they're there. So when a tick bites you, three things happen. It numbs the skin like a surgeon. It gives you an anticoagulant so you don't bleed, and it gives you an antihistamine so you don't itch. And then about a day later, that antihistamine wears off, and you go back for a scratch, and you might get more than you bargained for. But I would say the average area I remove a tick, I don't know about you, Ashley, but the average area for me has been the groin in the past year. So the nether regions. So we want to always make sure we're checking those other regions and using if we live alone, using our mirrors wisely, to be able to see behind us when we're outside.
Mm-hmm. I also see like along the bra line for women, underneath the bra strap in the back is a common area. The next one is the American dog tick. You can see it's a much larger tick. It's brown and tan in color. If it's engorged, you probably can't miss it. It gets pretty big. It also is polymicrobial and can carry Rocky Mountain spotted fever and tularemia and other forms of rickettsia. We did have one tick that we had tested a couple of years ago that did test positive for Borrelia. However, that's not the norm, but potentially possible.
And we say ticks are sewers, and you just never know what it bit before. If it bit your furry friend and your furry friend has Lyme disease, and then it bit you, could have given it to you that way too. Always look at the legs, because the black legs, the brown legs, and there's another tick we'll get to later that has tan legs. Mm-hmm. And everyone that I've never seen in person, but everyone should know about it.
All right, the next tick is the Lone Star tick. So these are more common in the southern states. However, they are starting to move north. So we have had a few in Wisconsin. They have a white dot on their backs. They can transmit stari, as well as Ehrlichia and alpha-gal syndrome. So alpha-gal was in the news this year quite a bit. And it can cause you to become allergic to red meat or any byproduct of a mammal.
Or pork. Yeah, pork's a big one too.
Yep. So it can be pretty life-changing.
There was that case in New Jersey where someone died after having an unknown tick allergy to meat. So, but they say it's a 7-year allergy. So if you know someone with that, get some Benadryl out and maybe try some meat about 7 years later if you haven't been treated.
Okay, we're gonna go to this slide.
One back for 1 second. Most people don't realize when I talk to them that the tick lives 2 years. They don't die in the winter. Ask any taxidermist that pulls a carcass out to stuff it. The ticks come alive. They say about 1,000 ticks per deer, and they freeze in the winter. And Ashley would tell me stories when I moved here about ticks, crawling on top of the melting snow. So as soon as that temperature hits 32, 33, you have to be wary of ticks. They do freeze, and and they live 2 years. So we know that they mate on the deer, and there's another tick that we'll get to that actually lives way longer than that.
Another fun fact that is that the white-tailed deer is immune to Lyme disease. So the ticks do not contract Lyme from the deer.
They get it from the deer, the mice typically. So.
Want to talk about the soft tick?
Sure. Yeah. So that's a picture of a soft tick, and the soft tick is called ornithoros, and it only needs to be attached for about 15 minutes. They say it can go 15 months without a blood meal, and when you go up to grandma's cabin to go skiing, and then you come home and 2 weeks later you get cabin fever. This is what you got. You got tick-borne relapsing fever, typically Borrelia miyamotoi, coming from the soft tick. It's quite large. It's about 3 times bigger than the average deer tick, and like I said, it can go a pretty long time without a blood meal. So when you get a bullseye rash and nuisance in the dead of the winter, and you didn't go to Florida and fly south for the winter, there's a good chance you have this. I always show this picture to children, because to me, it puts new credence to the term, there's a monster under my bed. And children being the smallest to the ground, they're more likely to see this. I hope someday someone will bring one to me, but I've never seen one in person, but they're nasty little things. And you can see how that, when it's engorged, it almost looks like a beetle or something completely different. So that's why we always want to look at the legs. So white-legged. So if you find a creature like this, I always say when you get a tick on you, you want to remove it, get all the pieces off, and then you want to zip it up in a Ziploc bag and date the bag. Don't throw it away. You hope you never need that tick, but every once in a while you might. We know that the CDC criteria are pretty flawed, but we'll just say that, we'll run through them. The tick must be identified as a deer tick for them to treat you for Lyme disease. They say it must be attached for more than 36 hours, which we'll touch on in a moment. They say it must be removed in 72 hours. And if not, they give you a double dose of doxy, which there is zero evidence-based medicine to support that. In the double dose doxy studies, they followed you to a bullseye rash. That's it. And the single dose of doxy is more likely to prevent the bullseye rash from occurring. So at ILADS, there's no criteria for tick attachment. For Lyme disease, at least, they do we treat for deer tick. But again, if you have a bullseye rash, we're going to treat anyway. We recommend that tick is removed within 5 days. And we typically will start with an average 3-week course of doxycycline, typically with a refill. It is important to know that, so the ornithoros 15 minutes attached, they say Powassan virus is attached by 15 minutes, is transmitted in 15 minutes attachment. And these flawed studies that showed above 24 hours that the tick attached gave you Lyme disease, let's think about for a minute. So a tick attaches to you, and then 24 hours later, then it vomits up its guts and gives you a spirochete. Sounded a little flawed first time I heard it. In fact, in the more recent studies in ticks, they show multiple forms of Borrelia, cyst and spirochete form right in the mouth. So with that in mind, if the tick's attached, we're going to treat. So we want, because the whole goal is to prevent chronic Lyme disease.
So these are two maps. One is from 2023. These are Wisconsin maps. And one is the most recent one from 2024. So you can see that the prevalence of Lyme has increased in a lot of the counties in Wisconsin, particularly the north and the southwest. But it is growing, and these are just reported cases. So there's a lot of cases that have probably been missed because they don't have positive tests or they're not reported.
Typically with Vilas County, where I volunteer as the Department of Health, they don't report on EM rashes as a positive test. They only report on lab testing. We know the lab testing is flawed, but think about that. We have at least a dozen Lyme Borrelia. We have dozens of tick-borne relapsing Borrelia, and this is only Borrelia burgdorferi. And there's at least 9 Borrelia that I've seen in the Northwoods, a minimum of 5 in our tick studies out there in the front. But there's so many different Borrelia that just shows you this is probably the tip of the iceberg.
Okay. Okay. So this is a slide on Borrelia. So actually, this is actually your slide.
Okay, so around here we don't typically use the term Lyme disease because we're trying to change the vocabulary, and it's Lyme Borrelia or other Borrelia, including tick-borne relapsing Borrelia. So Lyme's disease or Lyme disease is really a Borrelia infection, and that's the better terminology. We know that Willy Burgdorfer discovered, if you will, and those quotes are hard quotes, Lyme disease after the outbreak in the 1970s. I'm from Long Island, New York, which is home of the Montauk knee. And these fishermen, they had a swollen knee and a round rash. And they called it Montauk spider bite because they didn't know any better. But now, after 5 years later, and the Lyme outbreak happened in Connecticut, now they know what they have. But it's important for to realize that there are dozens of types of Borrelia. So even though even a Lyme Western blot or a screen test is negative, you can easily have other Borrelia in there. And they've even, with the Western blot, they've even dumbed it down worse, if that's possible, in the last few years by doing this positive negative thing without showing us the bands. Because when we explain it to patients about IgM and IgG, they tend to get that, acute and chronic antibodies. When you explain to them that band 31 and 34 were removed from the Western blot in the late 90s for a vaccine that never quite rolled all the way out, and they've never been restored to the Western blot, you can always have a +2 bands on there somewhere. And many times we'll send IGeneX tests, and we may only get a 31 or a 34 on there. And those patients will ask them, but I'm sure they didn't have a vaccine. So showing us the bands is important. And even in local labs that we've seen have acquired the immunoblot, they still don't report, they omit the 31 and 34 bands, which is a little sad. But we have to recognize that there's multiple forms of Borrelia, so that's why we have to continue to rely upon our clinical judgment.
All right, so this is the symptoms of acute Lyme. So over here we have pictures or examples of an EM rash or a bullseye rash. The thing to keep in mind is that there are some studies that show only 20 to 30% of patients infected with Lyme will actually develop a bullseye rash. So if you get a bullseye rash, it is a diagnostic of Lyme or Borrelia, but it is not you don't have to have the rash to have Lyme disease. So the bottom one is the typical bullseye rash. If you go up to the left, you see a disseminated EM rash where you can have multiple lesions all over your body or multiple bullseye rashes. You can have a vesicular lesion where you have blisters, or it can just look like a cellulitis where it's an enlarging red area, oftentimes in an oval shape or a round shape. But there's multiple different ways that it can present. Other symptoms include fever, migrating joint pain, which is a hallmark of Lyme, neck stiffness, a lot of muscle pain, brain fog, fatigue, headaches, lots of different symptoms.
One other thing I'll say about the bullseye rash is when I show the picture in the office here, I'll say that this bullseye rash, the classic one with the 2 circles, so many times that outer ring is faded. You just don't see it. So you tend to see that central rash, then some clearing, and then back to peach. And the other thing people don't realize is that doxycycline is actually a bacteriostatic for Lyme. And when we have early disseminated Lyme disease, we tend to need to get into the brainstem because that's a CNS infection. There is a connection there between the CSF, between the CNS and the skin. It's from growth. And many times, if you have early disseminated Lyme disease, doxycycline is not going to be enough because at 100 milligrams twice a day, it does not really cross the blood-brain barrier. You tend to have to dose that at 200 to 300 milligrams twice a day to get it into the brain. And we all know from treatment that patients can barely tolerate for their stomach the 100 dose. Plus, a lot of times you're treating in the summertime. So many times we have to use other antibiotics to penetrate the CNS better. What we classically, mostly what we see is a splotchy kind of oval-like rash with a little crust in the middle. And if you do, even if you leave a tiny little part of that tick in there, it can cause some pretty severe histamine reaction.
So Dr. Thatcher kind of touched on this, but this is the CDC current testing. So it's basically 2 ELISA tests. So again, it doesn't give you the bands. So it used to start with this ELISA and this initial ELISA test, and then if that came back positive, it would go on to the Western blot. Well, now we've seen it going on to a second ELISA test where it's just splitting up into IgM and IgG, but you don't see any band. So it's not a Western blot. At the center here, if we can't get IGeneX, we will order a Western blot and not the screens, so not the ELISA tests.
What we, the thing is that, and what we'll see sometimes is the screening test is positive and then the second ELISA is negative. And a lot of times that's a tip off to us that it's tick-borne relapsing Borrelia. So it's not a false positive. It's that it's not picking up the classic Borrelia-Burgdorferi patterns. So, but it is picking up, typically band 41 is the one we think about for tick-borne relapsing fever. It's the tail of the Borrelia spirochete.
And this was a research study that came out in 2025 from the Bay Area Lyme Foundation. So they found that this screening test from the CDC missed up to 70% of early stage Lyme disease cases. And only 34% of patients who presented with a Lyme rash greater than 5 centimeters tested positive with the CDC's 2-tiered testing. So you can see it's not very reliable at all.
And interesting about the Lyme size, because I will tell patients that on kids, I'll see tiny little bullseyes. And on a cancer patient, I'll see a gigantic bullseye. And the bullseye rash, we should know, it is an immune reaction. Your body's literally putting a target on it. But it's for a limited time, it's not permanent. And whether you treat or not, the bullseye goes away, which is also confusing. So anytime there's a rash, we have to tell the patients to take a picture, use that, as my uncle would say, the most powerful computer in the world is right in your pocket. Use that camera, take the picture, track the lesion. Because so many times what an ER or urgent care doesn't think is a bullseye, it's on that list somewhere of one of those EM rashes.
Okay, so these are some differences between IDSA guidelines and ILADS for treatment of tick bites and Lyme. So ILADS, their diagnostic criteria has a greater emphasis on clinical assessment of patient symptoms. So it's more of a clinical diagnosis. So you take into consideration your history of tick bites, your risk of tick bites, your symptom complex, if you live in a Lyme endemic region, and testing goes into that as well. But if you have a negative test, it doesn't rule it out. For preventative treatment, we do 20 days of doxycycline. Again, there's no time attachment criteria, and we don't treat just deer tick bites, but we will treat every deer tick bite. Acute infections are anywhere from 4 to 6 weeks of doxycycline. And if you have chronic symptoms or persistent symptoms, they would recommend retreatment with antibiotics or combinations of antibiotics for chronic Lyme and on ongoing symptoms. The Infectious Disease Society of America, their diagnostic criteria has a greater reliance on lab tests and that bullseye rash. We already went over the preventative treatment criteria. It's a lot more strict, and you get that 1 dose of doxy. Treatment of acute Lyme is now down to 10 days of doxycycline, which is nowhere near long enough. We see a lot of patients that do that 10-day course of doxy and come back with persistent symptoms or not even better at all yet. For persistent symptoms, they don't recommend retreatment unless you have unresolved Lyme arthritis, carditis, or neurological symptoms.
The interesting thing about the 3 weeks and the 6 weeks is at 10 days of doxy, it's still not quite long enough for anaplasmosis or some of the other things that will be easily treatable with doxy. So 2 to 3 weeks of doxy will tend to cover most of the other easily testable tick-borne diseases that we would see: rickettsia, anaplasma, ehrlichia. The Borrelia spirochete changes its protein coat about every 4 weeks, and that's how we get these kind of recurrent symptoms on a 4-week cycle. The body loses it every 4 weeks, so that could look like the every 4-week 2-day headache, or the every 4-week 3-day sinus infection. Could be headaches on the moon cycle. So when we speak to providers at our webinars, we tend to tell them, give the 3 weeks, give the 1 refill. And if the patient's not better at 4 weeks, and you have them take that refill, and at least you've done your part, even if you can't recommend the herbs and the other things we would tend to use. But so 6 weeks of doxycycline, 4 weeks of any antibiotic is long enough to get into the brain by infectious disease criteria. 6 weeks for bone infections, 12 for heart. So considering the organs that are affected, when I see a Lyme carditis patient, I tend to push it closer to the 12 weeks. Depending on the case, and we have seen some of those cases here. That debilitating new onset AFib. Lyme carditis is the more end stage Lyme carditis that affected the late Neil Spector. If you don't know him, you should definitely look him up. He's an oncologist that spoke at our conference and gave us lots of recommendations. But yeah, so we tend to give the patients 3 weeks for the refill. We tell them to take that refill if they have the clinical positivity of Lyme disease.
So these are maps of anaplasmosis in Wisconsin and ehrlichiosis. You can usually spot an anaplasma or an ehrlichia patient when they come in the office. They're usually very, very sick, high fevers, confusion. They may have nausea, vomiting, diarrhea. You can see a lot of changes on their blood work. So elevated liver enzymes, low platelets, low white blood cell counts. It's really important to get these people on treatment sooner than later.
When acute anaplasma, and I hadn't seen as much acute anaplasma until I moved here in 2024, and I tend to think it looks the first few days like food poisoning: headaches, no appetite, sometimes abdominal pain, usually diarrhea sometimes. But then 5-6 days later, food poisoning will be gone. That patient goes to the ER and their liver enzymes are up. Someone hits a sepsis button and you're staying for a sleepover. No sepsis antibiotics are called doxycycline. And those patients still won't get better until finally they send someone in there that figures out maybe there was a tick bite involved in there. But as soon as they get the doxy, they turn around very quickly. Ehrlichia got a lot more news in this year, and then a lot more press this year, because the Asian longhorn tick, which is on the Michigan maps, it's in the UP, and it has crossed over here to upper Wisconsin. So we are seeing some there. We have some that people have brought in from the front, and that also carries ehrlichiosis. But we do classically see it from the wood tick, and people around here just feel they take a wood tick off, flick it away, and they're good. But when we analyze the ticks, number 2 in the North Woods is anaplasmosis, and the ticks that we've been brought. Ehrlichia is down the list. We don't see it as much, but again, not a lot of people are worried about wood ticks.
All right, the next one is babesiosis. So this one is a parasite that the deer tick can transmit. It causes a malaria-like illness. Some of the symptoms we see are air hunger, like you can't get a deep breath of air. Drenching night sweats are a hallmark of babesia. A lot of muscle pain. and headaches. It can be deadly for patients who don't have a spleen or immunocompromised patients. So it basically goes inside your red blood cells and destroys them. We can also see anemia with that as well.
And there are these 5 babesia in the Northwoods. The white-tailed deer is now carrying babesia oticoli, and there's the only real testing we know of is IGeneX for this. They say if you're drawing the blood for babesia, you really should do a finger stick because it likes to be in the capillary beds. If we diagnose someone or treat them for babesia, we tell them do not donate blood because they screen the blood with that NAT test, which is another PCR test. It's about 50% sensitive, not good for medicine, and it usually tests only for babesia microti. But chronic babesiosis is a big problem. We see a patient that's not turning around with doxycycline. We have to expand our treatment to cover for parasites, and babesiosis has very quick resistance. You add something, it works for a little while, then it falls off again, and then it's like a whack-a-mole. You're moving it around, you're treating the area, and you're trying all different drugs. So chronic babesiosis, it can also cause pretty big mood swings. Could be anxiety, could be rage. We think more about babesia and some of the other more classic co-infections other than Lyme when we're getting change in behavior or mood swings.
All right, the next one is Bartonella. And this is also a parasite, but this one can be transmitted by ticks, black flies, fleas, lice, cat scratches, dog bites, has lots of different vectors. It's a very, very complex infection, probably more complicated than even Borrelia. The common symptoms are headaches, a lot of mood disorders, swollen lymph nodes. We hear a lot of skin crawling sensations, or people will describe that they feel like they're vibrating, bladder irritability like interstitial cystitis, pain on the soles of the feet. We have a lot of patients that come in with a diagnosis of plantar fasciitis that hasn't been responsive to treatment, and their pain will resolve if you target Bartonella. A lot of nerve issues like tingling and numbness, and then we can see these skin marks called Bartonella tracts. So they basically look like stretch marks, but they're in places where you wouldn't normally see stretch marks. So it's interesting to see these marks on patients.
When we think about stretch marks, stretch marks are white. These are violaceous or purple striae, and they're not in Longer's lines. They're not on the natural planes of the skin. So when I trained in New Jersey, the #1 tick-borne disease in New Jersey is Bartonellosis. It's because of them biting flies. And we get patients with these marks on them, and then I refer them for biopsy to a Lyme litter provider, and they get better. So you can biopsy these marks and do a PCR on them. What we tend to see is the marks will flare up and then thin out. What the marks are is it's abnormal blood vessel growth. So we tend to follow VEGF in the bloodstream, vascular endothelial growth factor, for activity of Bartonella. So I tend to see it go down by at least 50% or more on repeat testing. But Bartonella has got to be the toughest thing we treat in this clinic because of the debilitating symptoms, especially the psychiatric symptoms. I always say if you can get it from a tick if you're unlucky, but the biting flies, dust mites, fleas, but lice, so a lice outbreak in a classroom and a kid suddenly has ADHD, that's Bartonella every single time. So keep that in mind for us. So we got to have a bug repellent, not just for ticks, but for other things as well.
So this is just a bit about the difference in definition surrounding chronic Lyme disease. So post-treatment Lyme disease syndrome is the CDC definition. It's the onset of any of the following subjective symptoms within 6 months of the diagnosis of Lyme disease, and persistence of continuous or relapsing symptoms for at least a 6-month period after completion of antibiotics. And those symptoms include fatigue, widespread pain, and complaints of cognitive difficulties. And then also the subjective symptoms, when present, result in substantial reduction of previous levels of occupational, educational, social, or personal activities. The ILADS defines chronic Lyme disease as a multi-system illness with a wide range of symptoms and or signs that are either continuously or intermittently present for a minimum of 6 months. And then the most recognized facet of this controversy is whether it is effective, appropriate, or acceptable to treat patients with longer courses of antibiotics based on the clinical diagnosis of chronic Lyme disease. Which I think we are making progress towards acceptance in that, but it still is definitely very much a controversy.
The interesting part of that first sentence there is the last word, antibiotic. So if you got Lyme cysts in the mouth, the only two drugs I could prescribe to your Walgreens will say that would treat Lyme cysts, there's only two of them. There's metronidazole and tindazole, and there's hydroxychloroquine, another more recently widespread rheumatology drug that gained some new controversy in the last 5 or 6 years. But other than that, basically we have herbs, and that's why one of the great growths of ILADS over the last decade is adding naturopathic doctors to the ILADS roles and having some of those stars from naturopathic medicine, present the evidence-based medicine on herbs. So actually, Ashley and I have instituted every acute patient that we see gets one antibiotic course, one probiotic, always a probiotic in there, and one single powerful herb that covers all 3 forms of Borrelia. And we've pushed our cure rate way above the accepted 90% cure rate for acute Lyme disease with that regimen. And that herb is typically a Peruvian cat's claw that we use. Because it's pretty specific for Lyme and only a few other things, whereas other herbs might cover more things.
Okay, so this is just a slide on the OCOT slice studies. So they basically took patients with a EM rash, and they treated them with the recommended course of doxycycline. And this is basically showing us that 38% of those patients still had persistent symptoms, and 14% of them were diagnosed with the CDC post-treatment Lyme disease syndrome, where it was affecting their everyday life and their ability to perform in their jobs in school. I believe this is an ongoing study that they're still collecting data on with John Alcott, who is part of I think it's John Hopkins.
I think so.
This is a slide on the cost of chronic Lyme disease. So they found that chronic Lyme disease costs the U.S. healthcare system between $712 million and $1.3 billion a year. In 2015, a study by LymeDisease.org found that 42% of patients reported having to quit or cut back on work, and less than half of that number reported receiving any help with disability, or reported receiving disability at some point. So you can see that it is a very debilitating disease, and anybody who has dealt with it or has a family member that has dealt with it knows the cost of this illness.
And they say 500,000 cases a year now of Lyme disease. You take any 2 cancers and add them up, and Lyme disease is still more. So we're glad to see that more recently in the news, we're getting a lot more attention in Washington, and which should only be a benefit to our chronic Lyme disease patients. Yeah, so every patient's got a different set of symptoms. We use the MSIDS template created by Dr. Horowitz to categorize those multisystemic inflammatory disease symptoms. The diagnosis is usually missed because you might have fibromyalgia, and I'll tell patients, well, Lyme likes the tendons, so to eat it's a little a major cause of fibromyalgia that gets missed. But fatigue, headaches, the fever may or may not be there. These might, at 102.2 degrees, your body can kill some spirochetes. But the Borrelia tends to migrate out of the bloodstream in the presence of a fever into the tissues. And a lot of patients will see, hey, I never quite got that fever, but then the body ache started. And that's a classic way we see Lyme. But certainly the regional muscle pain and the migratory pains are things that we see early on. things switch a little bit as the body is kind of trying to self-preserve itself longer term, or a lot of times it is crossing that, if it hasn't already crossed the blood-brain barrier. And we say that Lyme disease eats the cartilage in your joints and peels the lining off the nerves like a banana. So we're grateful that we have Lyme arthritis and Lyme neuropathy and even Lyme meningitis ICD-10 codes. They worked really hard with the Lyme working group in Washington to get those. So we have codes to bill for those symptoms, but it overlaps with so many other diseases that it's hard for the average doctor who didn't learn this in medical school, and I didn't, to know that. So I always say we got to forgive the providers because they don't know what they don't know. But again, our door is always open to try to collaborate or educate our colleagues. But this, this and looking well and being seen as complainers is something that our patients have seen. I would say our average chronic patient who's been sick for a year has probably been through a half a dozen or more providers. And sometimes they get to talk where, hey, this is something you're just gonna have to deal with, and let's get a hospice in here to talk to you. And because it's whether it's they're diagnosed incorrectly with ALS or MS or fibromyalgia, but luckily with the advent of the internet, there's a lot more educational outlets for our patients. So if they keep fighting for themselves, they will find what they need to get better. Hopefully they'll find us.
Right.
So this is an interesting slide. We always show this, and I always show this to my patients. I let them know that first number A there, the Borrelia spirochetes, that's what's swimming around. It's got that tail that helps it to swim. It's got the corkscrew shape that literally helps it to drill into the muscles. And what we see in the more recent research that that presented us at the ILADS conference is that we know that the protein sequence at the tail looks a lot like human muscle protein. And what they're finding is remnants of the spirochete being left behind in the muscles, and the body maybe sometimes when maybe the patient has been treated for years and they are better, if there's still broken fragments around Borrelia, the body might be attacking some of those as well. So many times we'll have to look into ways to decrease that autoimmunity. We know that strep makes proteins like in pandas that look like human proteins. And Bartonella has been shown by Magellan's researchers to biofilm the collagen. But that spirochete picture is an important one. That's A. B, I always tell the patient that right about now on your doxycycline, these cyst forms are being promoted and they're trying to wait it out. And after your 10 days of doxy, a couple of weeks later, when you're worse, it's those cyst forms that are opening up and slowly starting to replicate again. And C is our biofilm. And I don't remember learning anything about biofilm in medical school, but that's a hornet's nest of spirochetes there. We don't know what's in that hornet's nest. The Sensum Quorum of studying of biofilm is showing that perhaps Lyme and mold are husband and wife from that biofilm. Perhaps Babesia and Bartonella. There's some communication going on in there with these microbes, but you could have heavy metals in there. You could have mold. You could have viruses from when we used to have chickenpox parties. You never know what's in that biofilm. So you have to be very careful when you open up biofilm in a patient because you never know what's going to come out. So we tend to use things like toxin binders before we open biofilm and during the biofilm busting to make sure there's not other bad humors coming out of there. But studies showed over a decade ago that the chronic Lyme patient that gets better on treatment and worse off of it, it's that you have to clear out the biofilm to give them as close to a cure as we can get. So cyst busters, like it says in the slide there's those couple of drugs you could prescribe, one of them being a little more controversial these days, even though if you were pregnant, pretty much the only things I could use for Lyme disease would be ceftriaxone, azithromycin, and hydroxychloroquine. That's how safe it is. But we listed some of the herbs there that we tend to use. Some of them are powerful herbs. We use them by themselves. Some of them we use in tinctures that are specially designed to cover other viral reactivations or the yeast burden that a lot of our patients get who've been treated too long with antibiotics. So we try to get the patient stabilized with antibiotics is our mantra, and then we move on to the herbs to overlap and replace the antibiotics so that we don't tend to treat patients for years and years with antibiotics. That 6 to 12 weeks is a good sweet spot in there for antibiotics without causing too much damage to the gut. But we use different types of biofilm busters, and there's some of the names down there. And they work on different areas. Serapeptates will work on biofilm in the sinus and the mucous membranes. Biocidin, more in the especially for the gut. Lumbricokinase is the most powerful biofilm buster that we have, and tends to open that microcirculation. Okay, excellent.
So we kind of went over this. So these are just some of the treatment approaches that we use in combination. Everyone is different, so not everyone responds to the same combinations of things. So oftentimes it's a challenge to try to find what works for each patient, so that they're very patient specific plans. And then we also will address, if there's thyroid issues, if there's vitamin deficiencies, we address sleep, because it all can be connected with complex chronic tick-borne illness.
So we tend to do a pretty robust workup. I think right now it's like 36 labs that I check in the first visit, looking at potentially 12 labs against tick-borne diseases, 12 labs against viruses and funguses, some baseline inflammatory labs to help with indirect testing for Bartonella babesia. But yeah, we have a lot of times we'll see patients with Hashimoto's thyroiditis, and it may be due to reactivated Epstein-Barr that came from Lyme or Mycoplasma or Bartonella. We didn't even get to Mycoplasma today, but it's out there. It's in ticks. It might be in ticks, but it's definitely in spiders. And it's pretty prevalent. And in a lot of our patients, it's top 3 infections for chronic fatigue, MS, and also rheumatoid arthritis. So there are some more challenging protocols to tolerate, like the dapsone disulfiram protocol that we'll tend to use if it comes to that. There's another drug I won't mention by name on the list there that is a controversial parasite drug that many of our chronic Lyme patients with chronic babesia got for long COVID, and suddenly their chronic babesia was gone. So sometimes if we may use that for a couple of months with great success. Mm-hmm. So a couple of cases here. So I'll read them out. So a first case, and we'll give you guys a chance to answer. So 6-year-old, previously healthy girl with a sudden onset of class disruption, hyperactivity, poor concentration, sleepwalking. This was an actual case from New Jersey I had. They had thought she had ADHD. They put her on Adderall. She lost, she was a pretty thin girl as it was, but she lost 10 pounds, wasn't eating well. She had headaches, she had pretty severe anxiety. And we found these marks on her body. And I remember asking the mom, well, what are these? And she was like, well, thought maybe it was a growth spot, but we do have a cat. This poor girl was sleepwalking right out the front door in the winter. Any idea from the group? Just feel free to shout it out there what it might be.
Bartonella.
Excellent. Very good. It is Bartonella. So that's pretty subtle. So I always look on the flanks and the lower back and the belly too. And looking back from my family medicine days as a resident, I saw this way too often in New Jersey. Next case, you guys will get these. You're pretty smart. So a 32-year-old man with a sudden onset of teeth chattering chills, drenching sweats, band-like headache that wraps around like a vice grip, anxiety with bouts of rage, as well as air hunger. And air hunger can look like this. It can look like, looks like I'm upset, like I got something on my mind. But it's really the patient just feels like they just can't get the air in. A lot of times they'll be associated with rib soreness as well. Acute infection of this can cause kidney failure. I knew one kid, teenager, that wound up at Children's Hospital of Philadelphia on a kidney transplant because we didn't get to him in time. But typically and this happened to me a few times in my 9 years as a hospitalist, where the pathologist calls me and says, you have a Maltese cross in your blood in this patient. So any thoughts of the diagnosis is?
Babesia.
Excellent, very good. Really hard to get positive in the lab. So if we're pretty concerned for it, we might want to think about drawing they say a finger stick blood draw. It might be more likely to get Babesia positive in the blood. This one's pretty classic up here. So a 55-year-old, previously healthy female visiting the Northwoods this summer, presents with acute onset of an ice pick headache on the side of the head, as well as fevers, chills, refuses to eat, and didn't see a tick bite. And the labs showed elevated liver function tests. Any thoughts what this could be?
Osmosis.
Yeah, anaplasmosis tends to cause this particular ice pick kind of headache. And if you asked me before I moved here what the worst tick-borne illness headache, I would have said Barnell every time because it gets in the bones, loves bones. But after seeing my share of acute anaplasmosis patients, I gotta say, I agree with Ashley. They look rough and they look septic. I mean, I guess if I was the ER doc and I didn't know what I know, I probably would be admitting them for sepsis. But they do this again. They do this PCR test, which if you catch it just right, it might be positive. But many times, you just probably just want to do the antibody test. You know, anaplasma is not as slow growing. We say most of these microbes double every 20 minutes. Borrelia doubles about every 36 hours. So it's kind of like watching grass grow. So it sneaks up on you. Anaplasma is way quicker than that. These patients will be sick within a week and they'll be pretty rough. So they will be going to the hospital. Last case, 18-year-old male, very active, developed ADHD. I kind of gave you the sense already. Following a lice outbreak in a freshman college class, didn't respond to Adderall, quickly developed gastritis. But focus on the skin lesion. So sensation of bugs crawling on him, and he's become known as a picker. And I would see this on dialysis patients in the hospital all the time. And I would send the test, and it would come back positive. Then the question was, what am I going to do about it as a hospitalist? Not a lot. So any thought what that is? There's a diagnosis that goes along with the bug. So it is Bartonella, but we call that those are one of the lesions that looks a lot like ciliary angiomatosis. But we tend to see that kind of lesion like that, almost like kind of marble shape. We will see a bunch of little red dots sometimes, and again, sometimes we'll see those streaks. But anything in the skin is typically we're gonna more, especially when it's not temporary like a bullseye rash. We're gonna tend to associate that more with Bartonella because it has a propensity for skin, especially collagen and blood vessels. All right.
All right, so we're just gonna leave you with a quote. Chronic illness is trying to appear normal, both for yourself and others, with a body that is challenged on every level. And we just want everyone to know that there is hope for patients who are suffering with chronic tick-borne illnesses. Be an advocate for yourself as a patient and navigating the health system.
There's some references there. Thank you so much for preparing this for us. I will open it up now for questions, if anyone has any questions.
Britt, do you want me to?
You can or I can, whichever is fine. Do you want me to?
Yeah, go ahead.
Okay. Thank you, Dr. Thatcher. We do have a few questions here in the chat. Let's see. Is the prophylactic treatment done remotely or do they come into your office? Do you do any remote treatment?
Good question. Yeah, we do. We will see a tick by telemedicine. So we'll get calls from Michigan or Illinois. But a lot of times they'll still have a bullseye rash, so we'll tell them, well, your next visit is going to have to be in person. But yeah, we definitely. So just so you know, Ashley and I are both licensed in 4 states around here. So Illinois, Minnesota, Michigan, and of course, Wisconsin. And I also carried my North and South Carolina licenses up here. And over the winter, we added Florida, Colorado, Nevada, and Arizona for the snowbirds. So we also, so that way we can continue to have continuity of care when patients fly south or west for the winter. But yes, we will treat anyone for prophylactic tick bite in those states.
Great. Are your clinicians registered with PECOS so that Medicare will cover the IGeneX testing?
I don't know what PECOS is, but I will tell you that straight Medicare will A and B will cover 100% of IGeneX testing. However, the advantage, or as sometimes we say, the disadvantage plan, won't cover it. The United Healthcare or some of the other ones will override it. So Humana is another one. So when they have Medicare with Humana or United Healthcare, we usually won't bother. Sometimes if there's money in the budget, we'll do a modified IGeneX. We won't do all 7 tick-borne diseases. We'll just do the 3 Bs. which will still be about $1,200. But because the Lyme immunoblot was FDA approved over a year ago, where the hope is the rest of the dominoes are going to fall soon, where we get the Bartonella immunoblot and the Babesia immunoblot approved, and that will be huge, because then if you can test for 27 species of Bartonella, I mean, that, rather than just the 2 that we know of, they say Bartonella vinsoni is one of the hardest ones to treat of them all. That tends to come from the deer fly, but Babesia as well. We'll get many times on IGenics, we'll get it's species, it's genus positive, but it's not species yet. And that's how they found otocolloid for Babesia. So I don't know much about Pico, so I'll write that down. So I'll look into that. Haven't heard that either. But otherwise, if we know when a patient has straight Medicare, when they come here, we'll tend to draw the IGenics kit on the first visit. So
PICOS is the organization that physicians that are opted out of Medicare can be registered with, and then the Medicare will be covered labs that they order.
Interesting.
Well, we must be, because if we order labs on patients through Medicare, their labs are covered.
Yeah, their labs are 100% covered.
Yeah.
When patients come in with Medicare, they can usually, even if they come from a different healthcare system, usually they have the option to draw the labs right here, which makes it a little easier for us to get the results. So we must be part of that, but we'll look into that. Thank you.
Although now, as a side note, personally, I had the IGenics testing done in November, and I've been disabled for quite a number of years with tick-borne illness, and I did the full panel, and I do have an Advantage plan through United Health Group, and it was covered 100%. So I did the full $2,700 testing, and it was covered.
Yeah, we've had that. What we used to do is we used to check the box on the order form that said, if it's not covered, contact the patient, because it may just be a small copay too with an Advantage plan. But I have had patients on the Advantage plan that have had it covered.
Yeah.
So it's, but you don't know until you send it in.
Yeah. And I was so sick that I was willing to take that gamble, but
Right.
yeah. But anyways.
That's good to hear. Maybe things have changed a little more recently with United Healthcare. So I had a new patient this morning with United Healthcare, and we said, well, let's just start treating you. Let's check the local labs first, and then when you come back, we could talk about that. So maybe we'll try that again. But yeah, that parachute clause is useful, because one of the only main drawbacks of this is cost, right? That's the main thing is the cost of treatment, the cost of testing, and we treat a lot of farmers. We're treating them blind. They don't have insurance. They don't really want to do anything. It's a hassle for them to get a CMP. But we're like, we got to check something sometimes. But there's plenty of people we treat blindly. That's why we rely on that clinical part. So
yeah. What do you recommend for prevention?
Prevention of what? Ticks?
Yeah.
Good question. So when I interviewed here in late 2023, after I met Ashley, I asked every single person I interviewed with what they would use, and I got a lot of non-answers. So most people know about Dieteroff. I got little girls. I'm not spraying them with Dieteroff. Most people have heard by now about permethrin. So whether it's impregnated clothing or spraying it on your clothes, but we'll still see turkey hunters with bullseye rashes. So that's not enough. Picardin is what Dr. Horowitz always recommends for the skin, and that's somewhat safer than some of the other chemicals. But we now carry No Bite Me, which is a set of herbs. And I always say, if you came to my house, my wife would spray you with cedarwood oil because she's a big believer. But it's cedarwood oil, rosemary, thyme, clove, oregano, geranium, and a couple other things. And it's a set of herbs. It's been around for a very long time. You put it on the wrists, the ankles, and the back of the neck, a little extra up top for me. And I can go out to the Minocquabats and see things flying around. Nothing's landing. So it works for mosquitoes and the biting flies and ticks. We tried out a couple of newer local tick repellents this summer with mixed results. So I don't think a clove spray by itself is enough. But cedarwood oil is a good way to go if you're buying one thing. But try that No Bite Me thing. It's a paste. So my kids know if they're going outside, they just dip their fingers in and just kind of spread it. It's very safe. It can also be used as an after bite cream too. So that is one thing there. But yeah, prevention is the key. We got to prevent. We can't be afraid of the jungle, or the woods, I should say. It is a jungle out there with ticks, but we can't be afraid. We got to get back into nature where we belong, and we got to have a prophylactic. That's all.
Yeah.
Can
When
you
you
write
said-
that in the chat, please? The name of that?
It's
No
called
Bite
No
Me?
Bite Me.
Oh, okay.
What is it?
No
No
Bite
Bites Me. It's made by Sally Ander. They've been a company that's been around for, I think it's 40 or 50 years. You can find it on Amazon pretty easily. We do carry it now. We've had it approved by Aspires to carry. So we're ready for the tick season in April. And I lost a bet with Ashley last year. I was about a month late in the first tick bite. She said April and she was right. So as soon as the snow thaws, they're out. So I'm looking for blood. And the other thing we see, there's different seasons, right? So we see, I think I just reviewed the data for 2025, and April and May and June are rough. And then July, after 4th of July, tick bites tend to die down a little bit around here. We'll still get them, but they'll be less. But then all those acute Lyme patients that didn't get properly treated will march in. So then our acute cases will fly up. But then September, and I learned this all too at my own pups. September is tick drop season when the deer migrate. The ticks are looking for new blood. So we'll see a flare in bites around then. And then, of course, when the turkey hunters come out, when they're deer dressing, is a term I had to learn in the Northwoods. So you're dressing the deer and you're not looking for tick bites on you. You can't feel them, right? So, because they numb the skin. So there's a couple little blips that we see along there too. And again, we get an acute case in the dead of February, where the bullseye rests. It's probably tick-borne relapsing fever, unless they traveled somewhere out into the warm.
When you were talking about the turkey hunters having bullseyes, were you meaning I think you kind of like wrapped it into the same sentence, like they were treating their clothing with permethrin and still had it, so you didn't feel that
They had the
permethrin
full,
was
it's called a Limitech. It's like a full body garb. It's supposed to
Okay.
prevent tick bites, but they still find a way onto the skin. So you have to have something natural for the skin as well, or whatever.
Okay. I hadn't heard that before. Is the current administration RFK making any changes to the IDSA guidelines? Do you know?
Well, I mean, they just had that roundtable last month, so we'll have to wait
Yeah.
and see. But we expect big things later this year.
Yeah.
Obviously, we're working at a pretty fast pace so far, but they're battling on a lot of fronts. And getting the toxins out of our food is going to help a lot of our Lyme patients, because one thing I heard recently that makes a lot of sense is, you think about it, Lyme disease, but what else left the door open on your immune system? Why did maybe another patient that got a tick bite didn't get as sick as you? Is it the pest? Is it the chemicals in the foods? Is it the GMOs? Are there stressors in your life? Or is there some unresolved trauma? So that's why at our clinic, we have to take a holistic approach to heal the patient from head to toe. And that's obviously a difference than what mainstream medicine does. You break it into parts. Your rheumatologist is not testing for infectious diseases, because if he thinks there's an infection, he'll send you to his ID buddy. Whereas we tend to correlate mycoplasma, Lyme disease, and CMV with rheumatoid arthritis. So linking those kind of things up. I mean, they've already mapped out, most cancers have been mapped to a microbe. If you genetically sequence a tumor, you find Bartonella, you find Borrelia, you find Acinetobacter, you find Epstein-Barr, you find all kinds of stuff. But who sequences their tumors? That's something the late and great Neil Spector, with one of his last breaths, told us to do. So we have to put the whole patient back together, because they've been fragmented by medicine these days. And you put the whole patient back together. Sometimes you have to get them off that fight or flight response by using neuromodulation. That was the big talk of ILADS this year, was mitochondrial failure and neuromodulation. For the patients that you've treated long enough and they should have been better by now, why aren't they? And giving us a different approach to those kind of patients.
Good. Sticks, I think your question has kind of been answered. She says living in Wisconsin. Sticks lives in Madison. She said living in Wisconsin, ongoing prevention is necessary. So I think we covered that with the permethrin and the sprays and the oils. Is there an internal herb taken orally ongoing that annoys ticks from biting?
Not yet. I think I always tell patients what I do, because I try to treat you like my own family. And if I know I'm going on a hike, I'm probably, because I have a stock of it, I'm taking a full drop or a cat's claw before I go, because that's going to cover all. But There is some interesting study in Africa that showed cattle that were given ivermectin for parasites didn't have ticks attached. But we're not quite in the political climate to think that kind of study on yet. But I think that it could get expensive investing in herbs. But I think the key is just checking yourself with the buddy system, making sure you check the bathing suit parts as well. I don't necessarily throw my clothes in the dryer when I get out. It's kind of weird, but I definitely take those clothes off and leave them far away from my bedroom because too many patients will find a tick when they're in bed. So, and I always remember my dad lining us up as a kid in Long Island and checking our head, and he would burn them off with a match, which I don't recommend. But making sure you have a good way to remove a tick safely and intact is key too, and not to panic, so a tick's attached to you. Again, we're bullish and we think appropriately so for treating any tick bite. But there will be some patients that want to wait it out and see. And when we analyze our tick studies that actually collected up front for over 5 years, more than approximately half those ticks have Borrelia in it, and half the ones that did had a second Borrelia in there. And there are things like powassan that. The main test we have is a spinal fluid test. So every once in a while, you want to test that tick too. So I recommend holding on to that tick for a couple of months, and whether you seek treatment or not, at least you have in your mind, you made a memory, you have that evidence there. But yeah, it's hard to say. If one full drop or a cemento, if I told everyone to do that, cat's claw, there'll be patients that can't tolerate 3 drops of cat's claw on an acute case, and that's a sign to us that this is an acute on chronic or a Bartonella case too. So that's one of the things we do find with the herbs every once in a while. Is a patient that is intolerable to it might lead to tell us more about their chronic old age arthritis. May not be old age arthritis after all. So we got to be careful telling patients to blast themselves with herbs before they go, because it could cause a herx when they're not even doing anything.
That was my first thought when you said to prophylactically take a dropper full. I thought, oh my gosh, I would herx, I think. But yeah.
But that is one way to do it. But
yeah,
I probably wouldn't recommend that at this point.
Yeah. And then Pamela, thanks for putting a link in. For those of you who haven't looked at the chat, Pamela put the link to the No Bite Me in the chat, so you can click on that and see that. Then let's see the
No
next
disclosures on that. I have no disclosures.
Okay. How are your patients handling?
Not be so chemically induced. That's all.
Yeah. How are your patients handling COVID? Do you see their chronic symptoms worsen after COVID?
I know from my side of the clinic, I'll have patients that are 6, 7 months in, they're doing pretty good, and then they get COVID, and it does throw them off. And they'll be like, I was so close, But I got a list of about 12 things that I use in the hospital that I would use in my COVID patients for 4.5 years. So I did a lot of research on SARS-1 when COVID came out, and they said, you can't use this, you can't use that. So long story short is I researched all the things that inhibit spike protein, and we already use a lot of them. Resveratrol, curcumin, DGCG, bromelain, other things like that. But yeah, it's certainly if your immune system is beat up and you get the most toxic thing our genetics has ever seen, then yeah, good chance you're going to be a little worse.
Yeah.
What else do you guys got?
Dix, I don't know. Do you want to ask your question in person? Take yourself off mute, because it looks like you're asking again for prevention. Maybe we're not asking exactly what you're wanting us to ask. I'll move on to the next. Oh, go ahead. Go ahead.
Yeah, I've had it for 35 years, and there's no way I can spray myself every time I open the door. So I did talk to a Lyme literate doctor who said to take Cistus and Canis as a tincture, and I can only take like 5 to 10 drops, and I actually brush my teeth with it, and I get it right into the saliva every single day. And I have never, not one time ever, seen a bite. I did get an oval rash though, initially, and I got it from the cross. I got an oval rash without a bullseye. And of course, the doctor said it was nothing. But
yeah, sounds a little suspicious though.
That was in 1989. So I never have actually I've just never seen a bite, you know, and I mean, I have to go outside and take my trash out. I have to go outside and get in the car. I can never spray. I have my spray in the car door. But like you said, they come out when it's out right now. It's 40 degrees outside.
Wow.
I have to have something 24/7.
Do
Well,
you
again,
wear,
and using little amounts of the no bite me on your ankles, if you're only out for a short time, might be enough. But
That wouldn't even
it's like
touch it for me because I live here.
yeah.
I mean, I go outside. I must have walked outside 10 times today to go to the doctor, to go to church, to go to the store. I mean, I would be sprayed up. I would stink if I had to spray
Well,
every
again, don't bite me.
It's 40 degrees out.
And it lasts a very long time. I'm still working on a jar from 2 summers ago. So we don't need.
But what I'm saying, I'm not saying about cost. I'm not saying about dosage. I'm saying exposure for me. I think I have to have something internally in my body.
Well, it makes you feel better too, right?
No, what? No, I don't know about making me feel better. I just don't, it helps me, and my testing works with like acupuncturists and nutritionalists. And anyway, what I know that I used to do the spray thing, but I could not keep up with the spray to spray my body every time I open the door or the window. It's just not practical to do that when you live in Wisconsin unless you never go outside.
The permethrin is a good option because you can spray it on your shoes and it lasts for quite a while. You can also you can send your clothes, like your socks or your pants, into professional companies that will treat them with permethrin, and then they're good for like 6 months. So if you have certain shoes that you wear on a regular basis, or treat all your socks, that would be a good option too, because you don't have to do anything then. They're already treated and they're going to last for 6 months if you get it professionally done.
You can buy permethrin impregnated pants. I call them fancy pants. Or socks. They gave out lime green socks with permethrin impregnated at the Lyme conference one year. Also, that liquid fence, I believe the number one ingredient is cedarwood oil. So putting that on your perimeter and so you go out in the garden is useful too. And the other thing, which sometimes they're guilty of in my own house, is don't feed deer. I know that they'll eat anything. They say the purple flowers they won't eat, but like Mr. Johnson says, deer are stupid. They'll eat it anyway.
They eat everything in my house.
Sticks on the MLA, on the Minnesota Lyme website, there's a link to Insect Shield, and you can either buy things that are impregnated with it. And I think you've heard Mary Collins from Insect Shield speak to our group a couple times. The treatment lasts 70 washings or 10 years, and you can also mail clothing in. You can get a bag, or you can do it per item. And I've done it where I just buy clothes that I like and that, are my style, so it doesn't look like I'm going on an African safari to go get the mail. But like
monocle included.
Yeah. But then you feel a sense of protection, and then you can top that off with some essential oils or, something like that. But
there is some research about magnets too that's coming out, that there may be certain frequencies or even magnets that may help repel them, but I'm still kind of looking into that. So if I start to see some better evidence about it, maybe something to think about. Is there something that you could wear that could help repel them with a force, almost like using your natural force field of your energy? So at least people are looking into these other, more holistic treatments. So that's a good thing.
Yeah, good. And then Dr. Verkota said, thanks for your presentation. Buhner recommended astragalus 500 milligrams 4 times a day for prevention.
Oh, that's interesting.
That's too much for someone like me. That's a lot of herb, man. I can't take that. I mean,
I don't know which forms of Borrelia astragalus. I always called it astragalus. Maybe I say it wrong, but
I don't know. I've never said that word before.
I have a nice chart from Dr. Shore about which herbs treat which forms, and I don't know if the astragalus is on there, but so I'd be curious to know if it treats the cyst form too, because what we want in an herb is an herb that treats both forms, acute and cyst form, because we want to make sure we cover the ones that roll up at the balls. And that's why we chose Cemento or Cat's Claw, I should say the brand name, because it covers all three forms. So if there's not much biofilm and it's an acute case, it should be no big deal to cover Lyme biofilm from starting to develop.
Yep.
We want an herb that covers all three. And so Chinese skullcap, Japanese knotweed would tend to be on the list. But and I will use Chinese skullcap if I'm worried about clinical babesia, but knotweed, when we have the whole tincture, and it's pretty rough. So I'd be leery putting on an acute case, but it treats so many other things. Cryptolepis as well, just treats too many things that if you have a herxin, you won't really know are we herxing this or that. So that's why we tend to settle with cat's claw, because it's we know that the Barne patient will flare on it, but it'll otherwise treat arthritis, and it'll treat viruses, and so it's a pretty versatile herb, cat's claw.
Good. Well, thank you so much. This has been so informative, and yeah, it's nice to know that you're in our neck of the woods.
Mhm.
Thank you for being
Thank
here
you.
tonight. I know you're probably supposed to be at dinner with your families, but we thank you for being here with us tonight.
Thank you.
So
Thank
much.
you. And it's wonderful to hear about, a clinic. 4 hours away isn't that bad,
Yeah. Yeah, and we do, so with our chronic cases, we require the first visit to be in person, but everything after that can be telehealth. We do see our patients once a year in person, but we do a lot of telehealth visits. Yes.
So we make that pilgrimage up the mountain, as I like to say, driving up from Wausau. It's kind of like going up a mountain right there, up to we want to be the beacon of the North Woods, for patients afflicted with tick-borne disease. So, and hopefully, as this clinic continues to be successful, we're having our best winter yet so far, because of all the word of mouth referrals, that maybe with this week we can duplicate something like this, because most of my buddies at ILADS, they've treated plenty of chronic disease, but they don't see tick bites, and I don't see acute Lyme like Ashley and I do. So it's a very unique place that we work. But we know that there's a whole lot of landscape up here, and we could use more of these types of clinics in the future. So, so we hope to attract other people with interests that, whether they happen to learn 5 minutes about it in medical school, or they happen to got skin in the game because somebody they know suffered. But it's unfortunately going to take more people that are in the medical community that have other family members that are afflicted, to buy in, to learn more, because they just don't teach us in medical school. When I spoke to Aspirus family medicine residents last fall, I said, show of hands, who can tell me the different forms of Lyme disease in the body? And it was 0 hands. So if they're still not teaching it that way in medical school, we have to get these, that we have to start there. So I can work on my own medical school, but we have to have that buy-in on the education earlier. And that's easier said than done, using herbs that aren't quite FDA approved, or breaking rank from the IDSA guidelines and things like that, because it has to be in the educational curriculum. So.
One of the things Minnesota Lyme has done, one of our missions, is we help sponsor any doctor or medical professional who would like to attend the ILADS conventions.
Nice.
Someone did that for me today, and I'm very grateful.
So if you hear of anyone, or send them our way, because honestly, in the last 2 years, we haven't had any new doctors asked to
Apply
go.
for a grant. Yeah.
Well, social media is one thing that Ash and I have identified as a weakness. We need to find a way to get more visual on the social media. We're just trying to work through that in the background with Aspirus. But I think that it's why if we can get them to approve putting this up online, that's going to be a big help. We'll look to repost it on our own sites and things like that, because there is that network out there. We just have to use it. So
Yeah.
But we'll speak to anybody. We'll speak at churches. We'll speak at groups. I spoke with we spoke at multiple groups over the summer. We did this AHAC thing, which is like an educational for nursing and medical students that we spoke at last February, which was, I think we had 80 attendees. It was pretty successful. So those are the kind of things we got to get the young doctors when they're still malleable, when they haven't been pigeonholed into their habits and what they learn is all they got. But you have to also, providers have to always maintain a level of curiosity and interest, which that spirit's been broken over the last half decade, but we need to rekindle that.
Amen.
All right, there's no other questions. Ashley's got some young kids too at home. We're gonna get going now, but if you,
Okay.
Well, thank you so
but
much.
we will be glad, we would love to do this once a year for you guys. So let's, we can do this again next winter, if you like, or even a different time. So,
Great.
especially if it's well received. So we thank you again for having us. And, yeah, don't be afraid, but just be careful and use some kind of a natural prevention. And, but we have to get out there in nature and as way God intended it, if you do believe that. I do. So,
Yeah.
Thank you
Well,
very much.
just to plant a seed, if you guys come down to the cities on May 30th, last year at our picnic, we had about 30 people and a couple Lyme doctors came, and it was a good time to kind of chat with people and meet people. And, it would be great to see you there if you happen to be down in the cities. So, yeah.
My family's never been to Minnesota yet, so only to the airport. So it is something that I love a good reason to go there.
Good.
I'm going pretty close to there soon. I'm going right near St. Paul, but I know St. Paul's it's a real pretty city. So
Yeah.
it is after Memorial Day, right? That wouldn't be Memorial Day weekend.
It was the weekend. It's the weekend after, and it's the park that's just on the St. Paul side. There's Minnehaha Falls on the Minneapolis side, so it's probably 10 minutes from the airport. And we did it at a park not too far away last year, but the parking was hard and the restroom was kind of a big walk up a big hill, and so we got a different picnic shelter this year that looks a little bit more user friendly. So we're hoping for a good turnout.
And I heard there's a big mall there, and I got a bunch of little girls at home. So
There you go. Thanks a lot.
Great. Thank
You
you.
guys take
Thanks so
care.
much.
Thank you.
Thank you.